अच्छा अभी
Okay, so let's start. Respected seniors, teachers, friends, and my dear students, good evening to all. Myself, Dr. Sarwar Hashmi, on behalf of the Association of Oral and Maxillofacial Surgeons of India UP chapter and the Department of Health Research Human Resource Development, King George's Medical University, would like to welcome in the coming webinar on patient-specific implant. Dear friends, as you all know that the reconstruction of the maxillofacial area is very, very difficult and the challenging task for all of us. And especially the reconstruction of the post-tumor deformity, reconstruction of the post-cancer deformity, and the reconstruction of the post-trauma secondary deformities is again the challenging task for all of us. So for the dealing of this reconstruction of the maxillofacial area, there are various ways available, and the most acceptable one here is the autogenous bone graft. But here, the contouring of the autogenous bone graft is one of the very, very challenging tasks for not for the maxillofacial surgeon, even the plastic and reconstructive surgeons as well as academic surgeons. So with these thing in the mind, today we have the galaxy of our speakers, Dr. Sachin Rai, and he will talk on the three-dimensional maxillofacial reconstruction with patient-specific implant. Students, it's a like interesting topic because now it's a time for the 3D printing. As you all heard about the 3D printing, DICOM, and so on. So in the coming presentation, Dr. Sachin Rai would definitely help you about the current situation in the reconstruction of the maxillofacial area in terms of the 3D printer. So with these, I would like to start. First of all, I would like to welcome our two chairpersons of this session. So first of all, I would like to welcome Professor Kian Dubey. I just like to inform you about the Professor Dubey. Professor Dubey did the BDS and MDS from the King George's Medical University in 1980s and 83 respectively. Presently, he is working as the professor and the principal Saraswati Dental College. Earlier, he worked as a consultant in oral and maxillofacial surgeon PGI Rohtak, professor and head Department of Oral and Maxillofacial Surgery, Christian Dental College, Ludhiana, the principal JCD Dental College, Sirsa. He has many publications to his credit and invited numbers of times to deliver keynotes lecture. Recently, he was awarded Lifetime Achievement Award by the UPMSI conference held at Agra. The second chairperson of the session is Professor Naresh Sharma, and Professor Naresh Sharma did BDS and MDS from the King George's Medical University in 1998 and 2000 respectively. Presently, he is heading the Department of Oral and Maxillofacial Surgery, Faculty of Dental Sciences, Institute of Medical Sciences, Banaras Hindu University. He also served as a Dean, Faculty of Dental Sciences for the period of 2014 to 17. He has around 50 research publications published in various accredited journals and delivered guest lecture in the various platforms. Till today, he has supervised 5 PhD and the 16 mass MDS students. Dr. Naresh was also appointed table instructor in the AOCMF at Lucknow in 2011. So please welcome Professor Naresh Sharma and the Professor K.N. Dubey as the chairperson of this session. Uh, Today we have two chat coordinator of this session. One is Dr. Akhilesh Kumar and another one is Dr. Atish Kundu. So I'll just like to inform you brief about these two chat coordinator. Dr. Akhilesh Kumar did the BDS from the King George's Medical Universities and the MDS from the SCB Medical College, Cuttack. He has 40 research publications to his credit and invited as a guest speaker in the various platforms. And he's presently working as an associate professor in the Department of Oral and Maxillofacial Surgery, Faculty of Dental Sciences, Banaras Hindu University. Dr. Atish Kundu, presently he's taking the charge of the honorary treasurer, Association of Oral Maxillofacial Surgeons of India UP chapter, and he is consultant head and neck oncosurgeon and presently working as an associate professor in the Department of Oral Maxillofacial Surgery at the Rama University. So with this introduction, I would like to call Professor K.N. Dubey, sir, to please introduce the speaker of the day.
Yeah, I'm feeling very happy to introduce one of my young oral and maxillofacial surgeon, alumnus of King George Medical University, Dr. Sachin Rai, who did his BDS in 2000 and MDS in 2003 from King George's Medical University. And presently he's working as additional professor of oral and maxillofacial surgery in Postgraduate Institute of Medical Education and Research, Chandigarh. Uh, Dr. Sachin joined PGIMER Chandigarh in 2004 as senior resident, and he was also nominated for the Commonwealth Scholarship in 2008 by Ministry of HRD, New Delhi, and he has visited Southern General Hospital, Glasgow, UK in 2009. Dr. Sachin has been awarded the AOCMF Fellowship at Hanover Medical Hospital, Germany in 2015 and Fellowship of International College of Dentists in 2016. Dr. Sachin is presently the Vice President of IDA Chandigarh State Branch, and Dr. Sachin has a very interesting area of his work, expertise, as Dr. Hashmi has already mentioned, that he is working for patient specific implants, and his unit at PGI was the first in country to use patient specific implants successfully in 2015. He has done a lot of work, and his areas of interest are in maxillofacial trauma, pathology, and 3D reconstruction. And he has many publications to his credit, and he is a well-known person in the North India. And I welcome him to this webinar series and request him to share his screen and deliver his deliberations. Thank you so much.
Thanks a lot, sir.
Dr. Sachin,
Ji, sir.
before you start, I will like to introduce the moderator of this session,
Okay,
Dr.
okay,
Sarwar
great.
Hashmi. Yeah.
Ji, sir.
So it's indeed my pleasure to introduce our moderator, Dr. Sarwar Hashmi. It's to the audience, maybe he's new, but to me, it's more than 25 years association with him. He did his BDS and MDS both from King George's Medical University, completed MDS in 2003, and after that he pursued postgraduate diploma in hospital and healthcare management. He was awarded Young Scientist Visiting Fellowship by DST for training of head and neck oncology at Tata Hospital, Mumbai in 2010. He is also a PI of ICMR project on dental implants of Mount. He is examiner in various universities across the country. Under him, there are 71 publications, and he have authored 3 books and contributed to various chapters. He has been invited as guest speaker in international and national conferences, and presently he is working as a professor in Department of Oral Maxillofacial Surgery, Aligarh Muslim University, Aligarh. Thank you. Now I would like to invite Dr. Sachin Rai for this presentation.
Thanks a lot, boss. Respected chairperson, Professor Dubey, Professor Sharma, moderator, my very own Dr. Hashmi, senior members of the UPMSI, and dear colleagues and students, thank you for this opportunity. Without delaying any further, we'll just start with the presentation. So my presentation is on PSI, patient-specific implants. We were the first one to do that in India in 2015 and 16. The first one which we did was a zygoma midface reconstruction. And henceforth, we have been trying to build up infrastructure where we can do this for the poor patients or patients who have limited economic resources. That's what our aim is here. So to start with, it won't be incorrect if I say PSI is still in an incipient or nascent stage in India or countries like India. Reason being lack of infrastructure, the money involved, the price is still too high. I remember the first one which we tried to build up in 2015, it was costing us 6.5 lakhs. The best deal which we could get was 1.5 lakhs after 6 months. Eventually, we got it for rupees zero, actually, from a government institution. We were lucky to get that. But the prices are still high. But because of the increased demand and expertise, the prices are coming down, and the infrastructure across the country is building up, and a lot of technical institutes, including IITs or private colleges or institutes, are getting 3D printers, so already have it, and they are collaborating with various maxillofacial units or plastic units to build up PSI. So this presentation would be maybe for half an hour or 40 minutes, and I'll be briefly overviewing what PSI is, how is it built, how does the planning go, and I'll share few of our cases, which whatever we have done in 4-5 years, and then we'll conclude with a way ahead. So as the moderator said, there are various reconstructive materials present. The gold standard is still autogenous graft because of their easy bioavailability, less morbidity, good uptake, and almost zero cost, right? But the problem is with contouring and resorption. It is still there. Then we have various alloplastic materials, med pores, and various metallic alloplast materials. They have their own set of advantages and disadvantages, various osteotomies, and then free tissue transfers, where maybe it's soft tissue or hard tissue. But we all know the lack of 3D contour is a huge problem in autogenous bone graft, especially in maxillofacial region complex. Look at the picture on the screen. If you try to build up a zygoma with a fibula, it is almost impossible to copy the zygoma in the mirror image, or similarly for a mandible or a maxilla, that dentate segment of the maxilla or the mandible. It's quite difficult or near to impossible to contour your autogenous bones to fit in as a mirror image in the maxillofacial region. We don't have long bones like the one we have in limbs, hands, or legs. We have mostly bones we have a lot of angulations, contours, and different structures. Resorption has always been an issue, at least with non-vascularized grafts. We all have burnt our hands in cases of iliac crest, and then donor side morbidity. With alloplastic materials, we have foreign body reaction or infection and high extrusion rates. So there is still a search for an ideal 3D material which can fit into the craniofacial skull just like a normal bone and give or reproduce whatever it is the natural way. There are two more things which make it quite complex: the articulations of these bones with other bones and the function associated with it. Facial bones not only give a contour to our face, they support a lot of important vital structures. Like, for example, a zygoma supports the eyeball. If it is damaged or removed or pathologically involved, the position of the eyeball changes. We all have seen that, right? Similarly, with bones which are around the paranasal sinuses or the mandible. So all these has to be taken into consideration when we are planning to reconstruct a lost or damaged complex, maxillofacial complex. Okay. Just a second.
Share your screen.
Yeah, sure, ma'am.
Okay.
Okay, sorry for that. So the factors affecting the outcome in a 3D reconstruction of faces: preoperative evaluation of the defect. Now this can be done virtually on a computer screen, and it has helped us a lot in evaluating the defect which we'll be creating or which we already have because of the trauma or pathology, and then we can measure the implant and measure the defect, plan the implant, the angulation and the length and the width of it. Then implant material, whether it is metallic or non-metallic, whether it is able to restore 3D architecture, and lastly, the skill of the surgeon, which can again be gained over length of time. Okay, so 3D titanium implants or patient-specific implants are medical-grade titanium alloy using the technology of additive manufacturing in laser or electron beam manufacturing machine. Now, a thing about subtractive or additive manufacturing. Just for the knowledge of our students, our dental implants are made of subtractive manufacturing. You take a block of titanium and then you carve the dental implant out of it. Whereas a PSI is made by additive manufacturing. Okay? Like this. This is subtractive manufacturing. A lot of waste happens in subtractive manufacturing, but the finished product is very fine, microscopically or macroscopically, just like your dental implants are. The surface of the implant is very important in context of osseointegration. Hence, subtractive manufacturing is better for a dental implant. PSI holds its position by mechanical interlocking between the screw and the recipient bone. Hence, this can be manufactured by additive manufacturing. We build up layer wise and then we build up a structure which is not as refined as the one which we have created with a subtractive manufacturing. So how do we start with it? For example, this is a patient of a zygoma tumor of the left side, right? Now we acquire a CT scan or a CBCT and send us DICOM files in a pen drive or a CD to the manufacturer or the computer engineer, the engineer who is trying to build this up. What does he do? He removes the pathologically affected half of the skull from the screen and mirror images the normal side to the affected side, right? So the green skull is distally created on the screen now, which has a normal zygoma on the left side. Now on this normal left side, which is virtual and distally created, in collaboration with the surgeon, we sit down together and then we plan the extent of the PSI, whatever pathology would be removed, the extent of the PSI, where would the holes be, where would the screw go. So we need a buttress for those areas. We have to identify the buttress areas and then extend the PSI up to that area. While in the going up to the screw area, the PSI has to thin down, right? It can't have that kind of thickness the way it has in the body in context of zygoma. So where we would like to have thinning of the PSI, where we would like to have holes for the screw, and where we would like to have the bulk of the body, all these things can be planned on the computer. Once this planning is done, this file is still in the STL format, right? Now this sounds a bit of a distal vocabulary, but the file is still in the STL format. To go into the 3D printer, it has to be converted into SLI format. What is the SLI format? The whole of the PSI distally is broken into hundreds and thousands of layers. Each layer is of a millimicron kind of thin or thick, and the whole PSI distal is broken up into various layers. Now this SLI format in the layered manner goes in the 3D printer, and each layer is built up with the titanium powder, titanium alloy, like the one which is shown on the left side of the diagram. The right side shows the actual machine which CSIO has. Now CSIO is in Chandigarh. It is Central Scientific Instrument Organization, which comes under the Council of Scientific and Industrial Research, CSIR. And if I'm not wrong, CSIR comes under the Defense Ministry, if I'm not wrong. So this is the machine from which our PSI had been manufactured. Some of them, the machine costs around approx 8 crore to 9 crore, I guess. And this is a German-made EOS machine. Now this is the gross PSI which has been fabricated, and it is still attached to the platform, right? Once it comes out of the machine. Post-processing, removal of part from the platform by cutting, removal of supports or other aberrations, and then cleaning and finishing of the part, wiping, rinsing, and polishing. Then the PSI is ready for transport to the surgical unit. It can be autoclaved. It is a titanium alloy. So the use of PSI satisfies long felt need for precision fit because it mirror images the normal side to the affected side. Aesthetics and function, right? And reduced operating time. We don't have to bend the implants. We don't have to bend the orbital floor meshes or reconstruction plates. We just have to put it there and screw it in the normal recipient bed. So I'll be discussing 4 cases. The first 2 were of zygoma reconstruction. The third one was post-traumatic mid-phase deformity, where we used 2-piece PSIs. And the last one was, we did a mandibular reconstruction last year in 2019. So the first one, am I audible, ma'am?
Yes.
Okay. So the first one, the first case which we did in 2015 was the patient came to us with a draining sinus from right infravital region. You can see that there is a chronic inflammation and swelling there. His maxillary dentation there was slight discoloration of the central incisor, and there was denudation of the roots. Whole of the segment, the quadrant was mobile, and there was foul smell from the oral cavity. Okay, this was the draining sinus where pus used to drain for the last couple of months. His CBCT was classical of an osteomyelitis, moth-eaten appearance. The whole of the zygoma had gone. The whole of the maxilla on the right side had gone. The floor was involved, and the whole of the palate had gone. In the axial section, even the arch up to at least the middle of the arch is also gone. The whole of the bone is involved, and it seems to be a classical case of osteomyelitis. So we did a biopsy and a culture, and it came out to be a mucormycosis. So we planned a 2-staged surgery. 2-stage because we didn't have a PSI infrastructure or PSI in hand. We were still working on it. So in the first surgery, we removed the maxilla, the involved maxilla, the sinus lavage, and put the patient on oral posaconazole with this dose, 800 mg QID for 3 months on OPD basis. We didn't admit the patient, and we didn't start with lyophilized amphotericin B. The second stage, after few months, we planned the zygoma resection and reconstruction with PSI. Just to deviate for a second, we have a data of mucor patients, and we treat the immunocompetent ones with posaconazole. We don't use the gold standard lyophilized amphotericin B. We use amphotericin wherein we have diabetic patients with mucormycosis. In immunocompetent patients, we straight away put them on posaconazole on oral OPD basis. So it costs less compared to the price of the amphotericin and the hospital charges. This paper had 6 cases, a case series of 6 cases. Now we have a data of approximately 25 to 30 cases with us with posaconazole. So stage 1, we removed the maxilla under oral intubation, sinus lavage. The primary healing was satisfactory. He was put on a removable denture. Now this is the intermediate CBCT. The whole of the maxilla has gone, and the zygoma is still there, and the sinus drainage is less but persistent. Now we plan the PSI in this particular case. This is the image where we plan the PSI, the extent and the other dimensions of the right zygoma. And this was the final product which we had of titanium with a skin incision for infraorbital skin incision and a hemicoronal incision. we opened the site. Why an infrabatellar skin incision? Because we had to remove the sinus tract also. So infrabatellar skin incision and a bicoronal incision, we removed the pathological zygoma and then we put the PSI in its place and screwed it into normal bone. The post-op CBCT shows absolute mirror imaging. The contouring is almost near to normal. The anterior-posterior projection is normal. The transverse width is normal. The post-op picture, slight enough ophthalmos, if you see it very hardly. The width has been restored, the projection is restored, and there is no sinus. The sinus has healed. For the maxilla, he is still on a complete denture, and he is satisfied with it. The patient.
कहाँ चला गया ये?
Okay. The second case, a similar case, an 18-year-old female, a known case of intraosseous hemangioma. If you see at the face of the girl, 18-year-old young girl, there's swelling on the left side, and there's a draining sinus on the bottom of the cheek on the left side. On the second picture, you can see that there is swelling, hard bony swelling on the left side of the zygoma. The picture was classical of a tumor. The biopsy proved it to be an intraosseous hemangioma. The same plan was done for this particular female also. Intraoral incision and hemicoronal. The tumor was removed and the PSA was put in place. Appreciate the mirror imaging, the reproduction of the normal side to the affected site. The projection is all right. The transverse width is all right. Pre-op CT showing depicting the tumor and the post-op with the PSI in place. For a young female, this is the best thing which we could do if we had planned for a fibula or something else. It was near to impossible that we could have this kind of post-op presentation in those cases. So hence PSI has a very good results in these particular cases, and they are the best for this sort of patients. So the other views, the lateral view, the supralateral, and the inferior PNSS or SME view. Now the third case, this was quite difficult for us, and I'll show you the CT scan. This patient had a massive craniofacial injury. He had a head injury. He was under tracheostomy, under the trauma center care, under neurosurgeons. He had a CSF leak, and we were called in with this sort of pre-operative picture. Everything is shattered, right? So the neurosurgeons didn't allow us to do the mid face or the upper face. So what we did was, in the first surgery, we did the maxilla and the mandible to at least to have him a decent occlusion. He came to us after 6 months with occlusion intact and this sort of presentation. There's ocular dystopia, there's flattening of the left side, even the frontal bone depression is there, and mild ptosis is also there, right, in the left eye because of some neuronal injury. So in this particular case, there was no point of going to for open reduction and internal fixation. There is no point of reducing these bones after 6 months. It's not going to happen and just complicate it further. So we planned a 2-piece PSI. One as a onlay PSI for zygoma, because to camouflage the depression, and one to reconstruct the orbital flow. So 2-piece PSI were put in this particular patient. And this post-op picture, the maxilla and the mandible from the first surgery, and the 2-piece orbital floor and the zygoma onlay PSI in the second surgery. The pre-op status of orbital floor, there is no orbital floor actually in the pre-operative. So it was very hard to find a posterior stop or the medial stop and fix our orbital floor there, but we did manage to find a decent bone there, and his post-op picture improved. There was malar projection was restored, We put some fat in the temporal area intraoperatively in the same surgery, and the ocular dystopia was also corrected. The first three cases we published in our PGI journal in 2 years back, and then came our first mandibular PSI. Now, this case was a immunoblastoma, aggressive tumor. We resected it and did a fibula in this case. The fibula failed because of some vascular disturbance. It was exposed in the oral cavity. He was again shifted to the OT. The fibula was removed and a recon plate was put in so that we could plan something else for this young patient, right? So once the fibula failed, our microvascular surgeon refused to do it again with the same procedure. And then we had to find for a alternative. And then we designed and planned a mandibular PSI in shape of a trough, a tray, a perforated tray. The idea was to put in bone there from the posterior iliac crest so that hypothetically we could put in implants later on once everything gets healed normally. So that this is the PSI which we had built for the patient. Bone harvesting from the posterior iliac crest. A lot of bone was taken out. The whole tray was filled with bone. And the whole tray was carried to the recipient site and fixed with the ramal stems of the uh, mandible. His bony contour were restored. Everything was fine. The patient was regular on follow-ups, but the story didn't end there. He developed infection post-operatively, and it was very cumbersome. Actually, it took around 15-20 days for it to heal with a lot of antibiotics, high-end antibiotics. But once the infection set in, we were quite convinced that we would be losing on the grafted bone. And after 6 months or 1 year, when we did again a CT scan to evaluate the bone, it was almost lost. There was hardly any remnants there. So the idea of putting a bone there so that we could a dental plant couldn't work in this particular case. He is still on a removable denture, but yes, we could restore the mandibular continuity. So to conclude, titanium-based PSI have a biomechanical property similar to those of bones, good biocompatibility, and less infection rate. It is very good in case of static bones like zygoma. For the mandibular, which is moving, which is dynamic, we still have to find a way where we can say that it works for the mandible also. But for orbital floors, for zygoma, for frontal bone defects, it can work wonderfully. It reproduces the contours precisely and restores defects, giving us excellent aesthetic results. PSI in the zygomatic orbital reconstruction not only optimizes the overall facial appearance, especially in young patients, male, female, both, but also improves the quality of life of the patient. So the road ahead, porous implants. This is the next thing which is still under a lot of research. The weight of the PSI is quite high if you compare it, right? So carrying that much of weight for the rest of the life, if we can make it porous, if we can fill in cancellous bone in there, so that ultimately it merges with the normal bone. Again, it is a hypothetical situation. It's very difficult to build a porous PSI. That's what the engineers say. But this is happening somewhere. We did that in the mandibular tray or trough. But for a static bone like zygoma, it is still a hypothetical situation. But yes, somebody somewhere is working on it. And maybe in future, we will have very light-weighted porous titanium implants for orbital floors, zygomas, frontal bone defects. So that ends my brief overview, and thank you. Any queries, comments are welcome. Just that, as I said in the beginning, it's in a very incipient or nascent stage, and a lot of people are working on it. So we don't have a lot of data to say something concrete in this respect. But yes, we are slowly building up our base here. Thank you. Thanks a lot.
Thank you, Dr. Sachin. for your nice and excellent presentation. But I request to be available here for the question and answer
जी
session.
sir, बिल्कुल बिल्कुल.
So regarding audience, there is a notification from Dr. Divya Mehrotra ma'am regarding the certificate distribution of the complete programs. It will be on the 9th evening. So the attendance of the 9th evening is very, very important, and it will be in the twice ma'am. दो बार लिया जाएगा मैम. शुरू में भी एक बार देखा जाएगा और एक बार मिड ऑफ द प्रोग्राम में भी देखा जाएगा. And on the same day you will receive your certificate of presentation participation. Uh, and the certificates for all the chairpersons, chat coordinators, as well as the moderator will also be distributed on the 9th evening. Okay, ma'am?
Yes.
Yeah. So we have, in the meantime, we have two questions. The question number one from the Major General A.K. Nandi regarding the, Dr. Sachin, regarding the first case of mucormycosis of the maxilla. Huh?
जी sir.
Where you use the
Zygoma and maxilla.
yeah, zygoma and the maxilla, and you
जी
use
sir.
the antifungal posaconazole.
जी sir.
Okay, yeah, it's a new medicine. He asked about the any permanent solution for the lost maxilla and the zygoma part.
Permanent solution, PSI for a maxilla which carries the dentation, the maxilla and the mandible. We cannot have some metal which is protruding in the oral cavity. It would create a track, and ultimately it would infect the whole thing. So still for the maxilla, we can go for an autogenous bone graft, reconstruct the maxilla with a fibula, and then later on we can put a dental implant on it. That is still the gold standard to create a dentate segment of the maxilla and the mandible.
Okay. The second and the third question is also related to with this. Major General A.K. Nandi asked about the expenditure involved in the PSI. Dr. Sachin.
Okay, that's a relevant question, sir. So as I told, when we started this whole thing in 2015, we went to Melbourne in ICOMS and we started searching for manufacturer there. It was costing 6.5 lakhs. Ultimately, it came down to 1.5 lakhs. But then we came to know that CSIO, the institute in Chandigarh, has a 3D printer and they are looking for this sort of work. So the cost for the first case was 0. For the next few cases, it was approximately 1 to 1.5 lakhs.
Okay. Dr. Ranjit from AMU, he suggested for titanium mesh for the orbital floor reconstruction. Okay, thank you, Ranjit. Then the next one is after the expenditure, Major General Nandi again asked about the it is possible to use other material despite of titanium in PSI, Dr. Sachin?
Medpor has been competing with titanium since long. It's the only material which is still in competition with titanium. But again, as alloplastic material, it is less biocompatible compared to titanium. And we have seen or read a lot of complications associated with Medpor. And it is very difficult to take Medpor out once it is set in. So tomorrow, if you have to take the implant out for any other reason, be it a recurrence or a malignancy, it's very difficult to take the Medpor out. It would be easier to take the titanium PSI out, which is just fixed there with a screws and drills.
Yeah, Dr. Sachin. So
Yeah, there are
yes,
other
ma'am.
materials as well, because it's not only that we need to do 3D printing of PSI, even milling of PSI is being done. So some materials, some milling machines mill titanium, so that what Sachin called as subtractive
Manufacturing, ma'am. Yeah.
manufacturing, that can also be used. And rather than titanium, the other materials which are being used, especially for our battle floor, are the peak. So peak milling is also being done. So that is also an option, peak and pack.
And
Yeah.
Medpor, ma'am, cannot be patient specific. It comes into in a set of small, large, or big implants, and yet you have to uh, carve it and fix it there. You
Yes.
cannot specifically make a Medpor implant for a particular patient.
So Medpor has stock implant which
Yes,
are
ma'am.
available, so you
Yeah,
can
yeah.
modify them
But
accordingly.
ma'am, but the material are used for like 3D printing material, and I have read some article related to the scaffold reconstruction. They were used PGA and PLA also with the help of 3D printers. So it's for scaffold reconstruction, because without
Yes.
scaffold it's very difficult. Yeah. So some more question.
As Sachin, you showed the tray, mandibular tray where you had used bone grafts.
Ji,
So
ma'am.
I feel for the bone grafts to survive, they have to have bone surface contact. So on either side, if you have a good bone, and only in the center region you are using your tray, just as you use whenever you are using a non-vascularized bone graft, you have to have bone ends, good bone surface contact with normal
Mhm.
bone. Then the bone graft is going to survive. If the bone graft doesn't have that connection with the rest of the bone, then it doesn't survive. And if you look at the PSIs used for TMJ reconstruction as well as the reconstructed condylar heads, and there are different designs also for TMJ reconstruction. So the latest one, there is an article by LH where he has done a systematic review and meta-analysis of TMJRs, and there we read about Momart's modification. He has also used, because the problem with TMJRs is that rest of the condyle function is achieved, but the lateral pterygoid attachment is not being possible. So to have a lateral pterygoid uh, attached onto the condylar head, in that region, neck region, they have given this mesh condyle region, and there they fill in
Okay,
the
ma'am.
bone graft so that the
Mhm.
muscle when attached has the bone support as well. So that is a thing which is latest, uh, which is being studied. Yet the results will come later on, how whether this bone grafted material is surviving or not, because
Surviving or
rest
not, exactly.
rest of the condyle is solid, but
Ji.
only in the neck region they are using bone grafts in the titanium mesh and fixing the lateral pterygoid muscle.
Yeah.
So we'll see.
So
And the other
yeah.
thing in PSI, which is yet to come, which is in the future of PSI, is smart PSI. So that means they may be sensor based. So along with the PSIs, there may be a sensor which could talk about, which could read about the healing in that area. So localized healing, how is the, how much of bone is formed, is it mineralized or not? So that information can be achieved from the sensor. Or if there is any infection, so rate of healing, rate of ossification, and also sustained release of antibiotics. That is also a possibility through smart PSIs. So this is the next generation of PSI
Yeah.
where
Yeah.
you see all these changes.
Yeah, definitely it's the future for PSI. So the next question is from Ravi. He's asking about Dr. Sachin, what is
Ji.
your personal choice when you compare with the PSI with free fibula for the reconstruction of the maxillofacial area?
To build up a dentate segment.
Any reconstruction, yeah.
For the mandible, fibula would be the gold standard. If we can see, we tried fibula first in that case. We didn't go for a PSI immediately. So the cost of fibula, putting fibula is less compared to PSI. We can put implants later on. It has good bone strength. The success rate is quite high. So my first preference would be fibula, always fibula in these particular cases. It failed. That's why we had to plant the PSI.
Yeah, you're right. So Dr. Jitain already discussed about PMMA, polymath methacrylate, already discussed, because now this metal is also using for PSI. And
Uh,
Dr. Madan.
I went through an article, or I saw a group in Brazil who are printing the entire mandible in peak. So that is also, the entire mandible is not in titanium but in peak material.
Peak material, yes, yes, ma'am. So this is the future of these things. Uh, Madan asked about the experience of peak for PSI. Dr. Sachin,
I
your
don't have.
experience?
We have
Okay.
done frontal bone defects with peak
Yeah.
initially, and one or two of them got infected. So somehow we went back to autogenous bones for frontal bone defects. It's easier to harvest autogenous bone, and the success rate is quite high. So we somehow left peak midway, and we went back to autogenous bone grafts.
Yeah. That's thank you. I think it's a last question from Anupriya. Is there any age-related factor to be considered for the uses of patient-specific implant, Dr. Sachin?
For a static reconstruction like zygoma, age won't matter. For a dynamic bone like mandible, age could be an issue, especially when you are putting bone graft uh, and presuming that it would heal and eventually put a dental implant on it. So age would definitely be a point of consideration because of the general healing situation of the body. For a static bone, I doubt any age would be. I say that any age would be good.
Exactly. Since it is the discussion of the reconstruction, I think the like growing age is very important. Once the cessation of the growth is there, then it's better to think about the reconstruction of the maxillofacial area, as
Yes, for
Anupriya
the
has asked.
pediatric population, yes,
Exactly.
exactly. मैंने geriatric
Uh,
बताया था. Pediatric, yes, we can wait for the growth to occur
yeah,
completely if
yeah,
it is
that's
not
good.
a
That's good.
urgent situation.
Sachin, you use posaconazole in your first
In all
article.
the immunocompetent patients which we are getting in a lot actually. The first
Mhm,
one initially Mucor was associated with diabetes mellitus, but
mhm,
then for the last 10 years maybe we have seen increasing number of immunocompetent patients, young patients getting
mhm,
infected with mucormycosis. We had a
mhm,
hypothesis in our paper which we had published, and there are a lot of other studies also from microbiology journals where they
mhm,
have seen that there is an increase in mucor cases in immunocompetent patients. The one reason for that is increased use of steroids in case of inhalers and various other drugs, uh,
mhm.
systemic arthritis and all. A lot of other diseases have systemic steroids. Hence, in those cases, especially inhalation cases, that is one hypothesis that there's an increase in cases of mucormycosis. In those cases, sir, we are using posaconazole, and there's a lot of literature which is good evidence proving that posaconazole can be used as the only drug for mucormycosis.
Sir means Dr. Vidyaratan.
नहीं सर आपको बोला सर.
अच्छा. Actually,
the moment
मैं
we
थोड़ा
the moment we get a diabetic patient,
हाँ
we
हाँ
admit him, we start with amphotericin B, 3
exactly.
gram of ampho, and then we discharge him on posaconazole.
हाँ 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 मैं
ऐसे भी
थोड़ा सा जो मैं इस पेपर में जो थोड़ा सा सरप्राइज हो रहा था उसका ड्यूरेशन था बिकॉज यू यूज अप टू 3 months पोसाकोनाजोल.
जी
तो
सर.
लेकिन अभी तक लिटरेचर में शायद शॉर्टर ड्यूरेशन रिकमेंडेड है. हो सकता है कि और लिटरेचर हो या यू टुक हेल्प फ्रॉम योर माइक्रोबायोलॉजी डिपार्टमेंट इन योर
नहीं
इंस्टीट्यूशन.
सर, जितना जितना लिटरेचर हमने देखा है
हाँ हाँ.
उसमें लॉन्ग टर्म पोसाकोनाजोल था उसमें.
अच्छा लॉन्ग
लॉन्ग
टर्म है
टर्म था.
विदाउट एनी साइड इफेक्ट.
सिरप के फॉर्म में आती है. इनिशियली वो बाहर के
हाँ
एक इंडियन कंपनी बना रही है, तो इट्स क्वाइट चीप एक्चुअली. पहले तो काफी
हाँ
कॉस्टली थी.
सिरप हैं और 100 mg टैबलेट भी हैं.
पर लॉन्ग
ओके.
लॉन्ग टर्म है, लॉन्ग टर्म है.
सो आई थिंक दिस इज ऑल अबाउट लाइक अब कोई क्वेश्चन नहीं रह गया है. सो मैं मैम को हैंडओवर करने से पहले सचिन डॉक्टर सचिन को बहुत बहुत अपनी तरफ से मुबारकबाद दूंगा. एंड थैंक यू सो मच डॉक्टर सचिन फॉर योर वंडरफुल लेक्चर. और चूंकि मैंने भी सीखा और मुझे लगता है कि जो पीजीज हैं जो ट्रेनीज हैं यंग बडिंग मैक्स फैक्स सर्जन्स हैं क्योंकि अब जो साइंटिफिक फील्ड है वो लेटेस्ट का ट्रेंड है जमाना है. तो इस लेक्चर से सबने सीखा होगा और फ्यूचर में अपने इंस्टीट्यूशन में वो इनकॉर्पोरेट करने की कोशिश करेंगे. मैंने इससे पहले भी हम डॉक्टर सचिन से डिस्कस कर रहे थे रिगार्डिंग आर इंस्टीट्यूशन. तो हम लोग भी इस पे कुछ काम कर रहे हैं. वी आर वर्किंग विद द डिपार्टमेंट ऑफ मैकेनिकल इंजीनियरिंग So they have the machine, they have the
Ji.
DICOM machine, they have
Almost
STL.
every IIT, every good engineering college has a 3D printer, and IITs have increased just like AIMS have. So almost every state has one or two IITs. Every
Yeah,
unit can collaborate with those. They would be more than happy to do that. We have a IIT Ropar in right now in 50 kilometers from Chandigarh. We have an institute engineering college just next to PGI. So we
okay,
have two institutes, and third is CSI. We have three institutes in Chandigarh, which is a small town, who have 3D printers.
okay, that's good.
So any metro city can have a access to these kind of things.
Yeah. So thank you, Dr. Sachin, for your brilliant lecture over here. Now I am going to switch over to the screen to the Divya ma'am.
Sachin, very nice presentation, nice cases, beautifully illustrated. And we thank you for your participation and sharing your experience. It's a pleasure to present to you this certificate of appreciation.
Thank you, ma'am. Thanks a lot.
Yeah,
Virtual certificate, digital
yeah,
certificate.
it would reach
Nahin.
you by mail too. Yeah,
नहीं,
The new
लखनऊ भी आना
norm,
पड़ेगा,
the
लखनऊ भी
new
आना
norm of
पड़ेगा.
scientific presentation, the new normal.
the new normal. The next year we have to be practicing this only.
Exactly.
That
Seems
we
so,
have to
ma'am.
see,
Seems so.
we have to see each other digitally, virtually.
So this is all about today's presentation. I would like to thanks to our chairperson and the chart coordinator, and I would like to thanks to Divya ma'am for giving me opportunity to moderate this excellent scientific session. Thank you, ma'am, once again. Thank you,
Thank you, sir. Thank you,
Thank
ma'am.
you.
chairperson.
So the plan is 9th, we'll have attendance earlier in the session. So we'll have a Google form in the very beginning regarding your name and email address. And then in the end, we'll have a feedback from you all. So those who submit your feedback will receive your certificates by email.
Okay, thank you, ma'am. Thank you.
Okay, thank you, everyone.
Thank you.
Okay,
Thank you.
thank you, sir.